I want you to move from overwhelmed by information to confident in what really matters. I want to help you move from being unsure towards direction and purpose in your healthcare. I want to introduce you to health experts. I want to let you in on tough conversations on women's health. I want to give you a place where you can lean in and learn how to take care of yourself. Let's transform your health. Let's get clear on your goals. This is Women's Health Unplugged. I'm your host, Dr. Jordan Robertson, naturopathic doctor.
Hey there, it's Dr. Jordan Robertson. I'm a naturopathic doctor and I'm the host of Women's Health Unplugged. We have never done a bladder episode. I take it back. We have done an episode with maybe my favorite urogynecologist, Dr. Carolyn Best, years ago, that talked about frequent urination and options that were non-surgical, and we haven't done one since then. And I wanted to talk about UTIs. I wanted to talk about how to think about urinary tract infections, how to advocate for yourself if you're having UTIs. I want to talk about the changes in your risk of getting a UTI as we get older and start to transition towards menopause. I want to give you those tools. And then there actually is a little bit of evidence for how we can reduce our personal risk of UTIs. So we're going to talk about that too. I'm actually recording today's episode from a hotel. And it's interesting. I am here doing a menopause event actually at this hotel. And I didn't realize that it was the same hotel that I did some of my original hormone replacement therapy training at more than 10 years ago. And I'd forgotten the location that I had done this particular training until I walked past the breakfast table. So I had to walk through the lobby to get to the conference center. You actually have to walk kind of through the restaurant, and I passed this breakfast table. And I remember the third or fourth morning of the conference. And when I did my original hormone replacement therapy training, I did it over multiple weekends. I actually trained with medical doctors. It was an incredibly intense, almost mini residency style program that I'm not even sure is offered, honestly, to any longer. But at that time, it was this really hardcore course that I took. And even though there were medications in the course that were outside my scope of practice, I still learned about them. I spent a significant amount of time going through the literature and research on hormone therapy. And that was a long time ago. But it wasn't until I saw the breakfast table that I was like, this is that hotel that I did that course at. And I remember sitting at that table sort of wide-eyed and in absolute amazement at this course that basically deconstructed every belief I had had about hormone replacement therapy. They went through line by line looking at the Women's Health Initiative, the media, the portrayal of hormone therapy, and broke down every myth I had ever known. And at that time, I had been practicing for a little while, but I had just been certified with a prescribing license in Ontario. So if you're unaware, naturopathic doctors in Ontario and in British Columbia actually can have a prescribing license and prescribe medications, certain medications, including hormone replacement therapy. And so I was just about to sort of embark on this phase of my practice and basically had someone explode my brain with this relearning of what needed to happen for us to bring menopause care to the main stage. And I remember eating breakfast and I'm sitting back. Quite often I can actually remember what I've had for breakfast. I don't remember what I had. It must not have been fancy. I'll absolutely 100% of the time I'm going to remember an eggs Benedict or a great omelet or eggs with smoked salmon or something, but I don't remember this one. But I remember sitting there jotting in my notebook how this was going to transform my practice, that I was being better trained and going to be more confident in prescribing hormone therapy after this course. And that story is relevant because hormone replacement therapy actually does decrease the risk of urinary tract infections in women as they approach menopause. So absolutely relevant. But I'm recording this episode from a hotel, which is actually my very favorite place to record. It's generally quiet. I can sit and focus. And the very, very first episode that I recorded of Women's Health Unplugged was also done from a hotel. So let's talk about urinary tract infections. And this is going to be one of those topics that, like, if you don't feel like you need this topic because you've never had a UTI, you just put this baby in your back pocket and you can come back to it when you're ready to listen. For those of you that have ever had a UTI, I want you to listen to this because as we age, that risk of another one or more goes up. So if you have ever had a UTI, you're going to listen to this. And if you're falling into that camp of recurrent UTIs, and the definition of that is that you've had like 2 in 6 months or 3 in a year. Okay, so if in the last year you've had 2 to 3 UTIs, you technically are meeting that criteria for recurrent urinary tract infections. You are definitely going to want to listen. You're going to want to save this one. You might have to come back and listen a second time. Okay, but really for most people as they age, we are not immune to the potential risks of a urinary tract infection. They happen for lots of reasons, right? So obviously a plethora of bacteria in that neighborhood, that urogenital area has tons of bacteria in it. And often it's kept in this delicate balance of, I don't want to say good bacteria, bad bacteria. That sounds like everyone's always good and everyone's always bad, even though as we learn more and more about the bacteria in our body, too many of a good thing is also bad and very little of a bad thing usually isn't that bad. So rather than saying like yes, no, we're just going to say that there's a delicate balance of a diversity of microbes in that urogenital area. And under various circumstances, that's going to get disrupted. The one that women probably know the best is like, if you take antibiotics, then we may see an overgrowth of yeast and yeast infections. It's a great example of like an outward stressor, medication, putting pressure on that delicate balance of, flora. But that can happen for lots of reasons. And there are particular strains of E. coli and a handful of other bacteria that are more likely to cause a urinary tract infection. So not every strain of E. coli that would come from your colon has the potential to cause a UTI. There are very particular strains. But as we age and as our estrogen levels drop, our colonies of bacteria start to shift. The tone of that area actually also shifts. So our ability to urinate completely, not have urine left over in our bladder at the end of voiding, our ability to even sense what's happening in our bladder will shift and change. For many patients that struggle with nervous system conditions or diseases like MS, who have spinal cord injuries, who change their sensation of their bladder, like with diabetes, we'll see a change in the sensation of the bladder. So all of these things are kind of happening in the bladder as we age or as a person's chronic medical condition progresses. And that really does kind of set us up for this increased likelihood of having more urinary tract infections. And so specifically, we're going to talk about the risk around menopause and as hormone levels change. But certainly if you're seeing in yourself that your chronic condition, whatever that is, may also put some pressure on your bladder, no pun intended, pressure in the bladder, you're also going to kind of want to pay attention to this conversation and how we need to think about UTIs. So first off, I want to admit that I used to make a bit of a mistake when it came to urinary tract infections. And if women said they had a UTI, I didn't really want to believe them until I had a microscopy assessment of their urine, right? I wanted a culture of that stuff. I wanted to make sure that she had a UTI. And this is probably for two reasons. One, we generally discuss in the medical literature about how poor patients are at recounting their own life and situation. And I think that obviously that causes a whole host of problems, right? If the literature says we shouldn't really trust patients, it's not right? What it's trying to say is that sometimes patients are unaware of their own symptoms and need some guidance around how to report their symptoms. But we generally have a little bit of a tone in medical literature that patients don't know what's going on with their own bodies. But I also was a little concerned about how quick we were to prescribe antibiotics for people who said they had a UTI. And because I was coming out of naturopathic school, and I'm going to admit like a huge bias here, is that I kind of didn't want us to give antibiotics out like candy, right? I wanted us to have a bit more, we now call it antibiotic stewardship. I wanted us to have a little bit more stewardship around our prescribing. And it felt like any woman who ever said she had a UTI left with an antibiotic, whether or not she seemed to or not. And so I had this particular bias that we were giving out more antibiotics than we should. I also had this bias that women didn't know. We can't trust them. They have no idea. If they have a urinary tract infection, we got to test it. Turns out I was wrong. You do know if you have a UTI, especially if you've had one before. But the symptoms of a UTI are quite hallmark, and women actually know if they have a UTI, and we should believe them. And for the most part, we can just give them an antibiotic and it doesn't cause any harm. Imagine that, right? Like, we should listen to patients, and patients are right. However, the literature does say that we probably should be more mindful of giving out antibiotics that are not necessary. And what happens here with UTIs is a couple of things. One, people that go into the hospital for like lots of other reasons come home with a UTI. and I don't mean they actually come home with a UTI, but we are very likely to give women who go to the ER with irregular bleeding, with pelvic pain. As women get older, if women have a fever we can't explain or confusion, we send them home with an antibiotic for a UTI because we test them and they have bacteria in their urine, and so we think that all of their problems must be caused by UTI. We actually give out antibiotics in the hospital twice as often as we should for a UTI. I'm saying UTI in air quotes. So there is a problem. The other is the recurrent UTI situation. So for many people who've had more than one UTI in 6 months, they should be looked into more thoroughly. They should maybe be offered an additional solution on top of the antibiotic. They maybe didn't finish their antibiotic prescription and now they have the same UTI. It's just come back with a vengeance. So I wasn't completely wrong about us wanting to have better antibiotic stewardship, and certainly there's been big conversations in Canada, the US, UK around how we can prevent antibacterial resistance by being a little bit more prudent with our antibiotic prescribing for UTIs. But if you are at home and you feel like you are peeing razor blades, you have a UTI and the right thing to do is to have antibiotics. End of story. Where we maybe want to be curious is if you have another one, right? That's where we have some role to play, I think, as integrative practitioners. There is zero evidence to do anything for your UTI aside from just taking an antibiotic. We can't fix it any other way. Just take the antibiotic. The real conversation happens on the other side of treating your UTI to say, why did that happen? Why did it happen twice in 6 months? Why did it come back so fast? Is there anything else going on, right? That's where the curiosity really needs to lie with UTIs. Not can we muck around with cranberry and see if we can avoid the antibiotics, okay? So I want to set the stage there by saying, if you have a UTI, go to the doctor. Get the antibiotics, take them. Where I want you to get curious about your bladder health is thinking about that intersection between age, the rest of your medical care and health, your hormone status, and your bladder. Because those things are coming together to change your risk of a UTI as you get older. The other thing I want to call out here about bladder health, before we talk about the things you can do to support your own bladder health, is also mention that there are many other bladder things. Come on, Jordan, where's your words? Diagnoses that are related to the bladder that, feel like a UTI, kind of maybe sound like a UTI, but aren't a UTI. So both overactive bladder and interstitial cystitis, which has been renamed as painful bladder syndrome, okay? Both of those conditions also tend to happen in women over the age of 45, 55, 60. They also present with discomfort, with frequencies, with maybe some incontinence. They both have this, we look at I love Venn diagrams. Do you like Venn diagrams? I love a good Venn diagram. So we've got UTIs, we've got painful bladder syndrome. Both of them have pain, okay? UTIs might have blood in the urine. Painful bladder syndrome does not. Painful bladder syndrome probably hurts if we palpate or touch around your pubic bone. That does not usually happen with a UTI. So you can see there's an overlap in symptoms with pain, but they each have their own distinct symptoms as well. Overactive bladder and painful bladder syndrome tend to have increased frequency, meaning people hit the bathroom all the time. People with painful bladder syndrome are going to the bathroom because when their bladder gets full, it's uncomfortable. Whereas people with overactive bladder are going to the bathroom often because they're worried about being incontinent. So yes, frequency is there, but they have a different experience of that frequency. Overactive bladder typically doesn't have discomfort or pain. Okay, so you can see overactive bladder and UTIs maybe both have some urgency, like, shoot, I gotta go. But urinary tract infections have blood in the urine, have pain. So we want to make sure that we are appropriately diagnosing whatever's going on with your bladder. And if you're that person who seems to be getting a UTI, left, right, and center, we really have to question whether or not we're right that it's a UTI in the first place, or whether there is some other thing that we should be exploring with you. So I want to call that out also, that there are other uncomfortable things that happen in the bladder as we age that are maybe going to change your experience of your bladder health, and we do want to be aware of them so that we can treat you appropriately. Talk about antibiotic stewardship. Giving antibiotics for an infection that's not there is also a challenge. So if you're on your third or fourth round of antibiotics for an UTI, which I'm saying in air quotes, then maybe we need to question the diagnosis, right? Maybe we need to look at this a little further. Maybe we need to do a culture on your urine and make sure that there's actually a UTI there. And it's common that I've worked with people in practice where they were treated for UTI, and then when their culture came back, there was nothing in their urine. And what they were experiencing was like really significant bladder irritation that was caused by something else. So it felt like a UTI, but maybe they fit that diagnostic criteria of painful bladder syndrome better, right? So let's pay attention to that as well. I know I'm focusing a little bit on that UTI piece today, but just thinking about bladder health in general for women, it is important that you track your experience of your bladder, right? Are you peeing in the night because you got up because you have hot flashes? Because that's not really have anything to do with your bladder. Or, right, are you running to the bathroom because you're afraid of being incontinent? Or are you having frequency because a distended bladder is a painful bladder, right? Like, we need to think about all these things. And the more connected you can be with your bladder symptoms, the better feedback you can actually give your physician, and then you're going to get a better diagnosis. But if you just say, I'm urinating all the time, they're going to go with the most common reason that happens, which would maybe be UTI. So there are a couple of things that you can do for yourself that will help decrease your risk of having a UTI. There's not many, but there are a couple. And it's funny because I think the things that we think of, right? So if I said, what are the things that we can do as women to decrease the risk of UTI? You'd probably say behavior things like wiping from front to back. You probably would also say things like urinating after sex. Both of those things have persisted and live in all of the standard of care guidelines for people to support bladder health and reduce the risk of UTIs. Funnily, there's very little research on either of those two things. So if you're doing those things and they're not helping, it's not because you're not doing them properly, right? It's like the weight that we've put behind those two behaviors doesn't match with the level of evidence we have for doing those two behaviors. And sometimes that happens where we've got these historical things that we've recommended for decades and generations, and urologists and gynecologists from the 1800s have passed down these words of wisdom about urinating after sex. When the reality is that they're really not decreasing UTIs as much as we would think. And so don't feel like a huge failure if you get UTIs and you're worried that those two behaviors were ruining it for you. They don't have as much impact as you would think. The other myth that I want to bust is around sugar. So people that have diabetes do have an increased risk of UTIs. People who have diabetes also have glucose in their urine if they're poorly controlled. So not every diabetic has glucose in their urine. But if you're poorly controlled, or if it's brand new, your diagnosis, and you're not well medicated yet, etc., you might spill some glucose into your urine. And we thought for the longest time that was the only reason that people with diabetes got UTIs, was because there was sugar in their urine. And then that led us to have this recommendation that if you have a UTI, we should decrease the sugar that you eat, because then there won't be any sugar in your urine. I hope you can see the hole in this logic. So the vast majority of people do not have glucose in their urine, not at enough of really there should be none, but the average healthy person does not have enough glucose in their urine to grow bacteria. Even people who have diabetes are generally not putting a ton of sugar into their urine, and yet they get UTIs. So healthy people, whether you eat a donut or not, there is no sugar in your urine. So that's not causing your UTIs, and avoiding the donut is certainly not going to treat your UTI. And it's probably not going to prevent your next UTI. So I often will see this online, that if we're talking about urinary tract infections, that the dietary recommendation will be to avoid sugar. It just doesn't stand up in the research. And people who have diabetes who are getting UTIs are getting them for a variety of reasons. It's not just because of sugar in the urine. So if you have a UTI, you can have a donut. That said, there are some dietary patterns that do seem to reduce the risk of a subsequent or a future UTI. And the one that really stands out is around eating berries in your diet, and then of course cranberry. So eating berries in the diet does seem to reduce the risk of having a UTI. When we look at these larger studies where we watch women and see what people eat and see who gets UTIs, the people who eat the most berries get the least UTIs. So it's a great thing to consider. I mean, we like berries for lots of reasons. We're just going to add this reason to the list. Now we like berries because of bladders, even though there were many reasons we liked berries before that. But increasing your berry intake, if you're a person who's struggling with recurrent UTIs, may offer you some protection. It's not going to treat a UTI if you have one. Remember back at the beginning, I said you need antibiotics for that. But it may prevent a future UTI. And cranberry has been an interesting discussion. Like, I think if I say UTI, you might say cranberry, right? Cranberry juice, cranberry capsules. What I want you to remember from this conversation, and now I've said it multiple times, is that a current UTI, so if you have a UTI right now, you need antibiotics. There is nothing we can do that fixes that without treating it with antibiotics. We've looked at this in a lot of different lights. What happens if we give you cranberry? Can we reduce your need for antibiotics? The answer, no. What if you drink lots of water? Can we reduce the need for antibiotics? The answer, no. There is nothing that treats a current UTI that's natural. Even some of the herbs that traditionally have been used for UTI, patients who use herbs for their UTIs end up in the hospital more often. They end up needing rescue antibiotics. They end up having way more blood in their urine. Don't treat your UTI naturally. Just don't. Prevention of a future UTI, that's where the evidence for cranberry actually starts to stand up. If you've had recurrent UTIs, then cranberry seems to decrease the chance of having another one. Okay, but it's not going to treat your current UTI. The last thing I want to touch on is hormone replacement therapy. So, vaginal estrogen is safe in literally almost everyone. And so, even if you have been considered to be a non-candidate, so you do not qualify for hormone replacement therapy, you probably qualify for vaginal estrogen. So this is a very inclusive conversation because whether you've had a health condition that means you can't have systemic hormones, like hormones in your whole body, you probably still qualify for vaginal estrogen. We are using vaginal estrogen in patients who've already had breast cancer. We're using vaginal estrogen in almost every patient. And what I said at the beginning was that microbiome change that happens at menopause, so when we lose our estrogen, it changes the bacteria that are capable of living vaginally. It changes our pelvic tone. It influences discomfort, so vaginal discomfort, and patients may have painful urination that isn't a UTI, but maybe is related to vaginal irritation. But using vaginal estrogen is actually a certified reason why we would use HRT. It is a confirmed treatment for recurrent UTIs. So remember what I said. If you have a UTI right this second, you're going to use antibiotics. But if we're trying to prevent future UTIs in patients who've had 2 in 6 months or 3 in 1 year, or if you've noticed the frequency has gone up since you turned menopausal or started to approach menopause, vaginal estrogen is a certified solution, FDA approved solution to decrease your risk of recurrent UTIs. So even if you aren't sexually active, even if you don't identify as having vaginal dryness per se, and yet your frequency of UTIs has gone up, that absolutely warrants a conversation with your practitioner. And I would even argue if you've had any kind of bladder change, and I know I'm going off of the evidence-beaten path a little bit, but there's lots of changes in discomfort, and even when we look at other lower urinary tract symptoms in people, incontinence, feelings of fullness, incomplete voiding, even pain. If you haven't tried vaginal estrogen and you're over the age of 45, you gotta give that a whirl, just to rule out that that's not part of the problem for you as an individual. So yes, the sign stamped, sealed, approved use for vaginal estrogen does decrease future UTIs. If you've had a change in urinary symptoms since heading into perimenopause, you deserve giving that an honest shot, because there is some other evidence that giving that a try, I know that doesn't sound very scientific when we say, yeah, give it a whirl, but there's evidence that we should try it as part of a comprehensive plan for people who have new bladder symptoms as they approach the age of menopause. And vaginal changes in menopause are one of those symptoms that never go away with time, right? Other parts of menopause go away with time, right? For most people, their hot flashes go away. For many people, their sleep recovers. Maybe it isn't perfect at postmenopause. Their mood may recover. Their cognitive changes recover. Vaginal tissue doesn't recover. And consequently, some urinary symptoms also don't recover. And so that's why I want you to understand that this is an option, not just because it's great, but also because for some people it's going to be necessary in order for us to decrease the quality of life changes that happen when we have so many bladder symptoms over the age of 45. I hope that was helpful. And just to reiterate, like, if you have a current UTI, you get antibiotics. I hope we agree but at this point in the podcast, I hope we agree on that one. And if you've felt otherwise, or if you felt like you had a UTI that did go away without using antibiotics, just know that statistically that is not the norm, right? That is not the majority. The majority, I'm going to hedge a bet and say almost all current UTIs need to be treated with antibiotics. And so that's a really important thing I want you to take away from this. What I also want you to take away from it is that it might not be a UTI. So I gave you a few other things you need to consider or think about. I gave you a few things that you need to track so that you can have a good conversation with your doctor. I also gave you a few things to consider when it comes to recurrent UTIs. The timing, right? 2 in 6 months, 3 in a year. You're meeting that definition of recurrent, and does warrant further investigation to make sure we're barking up the right tree and we're trying to kill the right bacteria. Okay, it absolutely requires that if you've had more UTIs than the average person in the last year. I also want you to know that there are some solutions out there to decrease your risk of recurrence if you've had a UTI, if this is a new thing for you, if your bladder symptoms are starting to creep in and creating some quality of life issues. I want you to know that there's some solutions, and that almost all of you listening qualify for vaginal estrogen regardless of your health history. And that is an important piece to bring up with your doctor. It's not just about sexual health. It's about your entire genitourinary system that suffers at the loss of estrogen. And I want you to have that language in your head and these tools in your toolkit so that you can approach your practitioner to be able to support you.
I hope you enjoyed that episode of Women's Health Unplugged. My goal is to help you feel more confident about your health. Please remember that what we talked about today in the podcast does not constitute medical advice, nor was a doctor-patient relationship formed. If you have questions about your healthcare or about how today's topic pertains to you, please take it up with your family doctor, your specialist, or someone on your health team.